Welcome, colleagues. Let's be honest, we've all been there. You've got a patient recovering from major abdominal surgery, you've placed a beautiful tap block, but the visceral pain is still breaking through. If a standard transversus abdominis plane block isn't quite cutting it for those extensive truncal procedures, you are exactly where you need to be. Today, we are diving deep into an advanced review explainer focused entirely on the Quadratus Lumborum, or QL block. First conceptualized by Dr. Blanco back in 2007, this interfascial plane block has evolved at an absolutely blistering pace. We've moved so far beyond simply calling it a posterior tap block. Over the course of this explainer, we are going to dissect the highly complex anatomy of the thoracolumbar fascia. We're going to decode the precise mechanisms that give us that coveted T7 down to L1 coverage, both somatic and visceral, and crucially, we'll meticulously break down the 4 distinct approaches to ensure you can execute this block flawlessly in theater. It's a dense topic, but a real game changer for your practice. Let's get straight into it.
Hello, anesthesiologists. Thank you for your hard work administering regional blocks today. Following the ESP block from last time, today we will look into the QL block. Bonjour, chers anesthésistes. Merci pour votre excellent travail lors de la réalisation des blocs régionaux aujourd'hui. Après le bloc ESP de la dernière fois, nous aborderons aujourd'hui le bloc QL.
For our roadmap today, we're covering 5 main areas. Section 1 will handle anatomy and mechanism. Section 2, the 4 QL approaches. Section 3 covers dosing and procedure guidelines. Section 4 is all about clinical indications and the latest evidence, and we'll wrap up with Section 5, safety and complications.
Section 1, Anatomy and Mechanism. Let's explore the thoracolumbar fascia.
To truly master the QL block, we have to fundamentally reorient our understanding of the posterior abdominal wall. The true secret to the profound multidermatomal analgesia we see with this technique doesn't actually lie inside the muscle belly itself. It lies in the highly complex, interwoven fascial network surrounding it, the thoracolumbar fascia. Anchoring our mental model with the standard sonographic baseline, we need to immediately locate the Quadratus Lumborum muscle. It's flanked by the psoas major anteriorly and the erector spinae posteriorly. And right there, serving as a stark, unforgiving acoustic landmark, is the transverse process. Now, the thoracolumbar fascia, or TLF, isn't just a simple sheath. It's a dynamic, connective tissue tubular structure formed by binding aponeuroses and multiple fascial layers. It completely envelops the back muscles and serves as a literal bridge connecting the anterolateral abdominal wall with the lumbar paravertebral region. Medially, it's firmly attached to the thoracic and lumbar vertebrae, but here is the kicker for us as anesthesiologists. Cranially, it is continuous with the endothoracic fascia via the lateral arcuate ligament, and caudally, it continues with the fascia iliaca. It is exactly this extensive craniocaudal fascial highway that allows our high-volume local anesthetic to spread so predictably into the thoracic paravertebral space.
Let's break down this thoracolumbar fascia into its 3 distinct layers, because understanding exactly where your needle tip sits among these layers is absolutely non-negotiable. First, we have the anterior layer. This sits, as you'd expect, anterior to the QL muscle. It blends medially with the fascia of the psoas major and laterally with the transverse salus fascia. An injection deposited here tends to spread cranially, slipping right under the lateral arcuate ligament straight to the endothoracic fascia. Next is the middle layer, located right between the erector spinae and the QL muscle. And finally, the posterior layer. Interestingly, this layer actually encloses the erector spinae entirely, effectively bypassing the QL muscle. But what makes the TLF incredibly fascinating, and why this block is so powerful, is its histology. The superficial layers contain a remarkably dense network of sympathetic nerve fibers, perfectly mingled with high and low threshold mechanoreceptors and nociceptors. When our local anesthetic bathes this area, we aren't just blocking somatic pain transmission, we are directly altering local circulation and resetting autonomic tone. That sympathetic blockade is a massive component of the QL block's unique analgesic profile.
Now, I want to draw your attention to a very specific, highly targeted anatomical zone, the lift, or the lumbar interfascial triangle. This is a brilliant little triangular fascial structure right where the middle lumbar fascia joins the deep lamina of the posterior layer, sitting perfectly on the lateral border of the erector spinae. Why does this tiny triangle matter so much to us in the theater? Because the lift is widely considered the optimal primary target for the QL2 block. Injecting your volume into this specific triangle acts as a highly efficient, almost pressurized conduit for local anesthetic spread. Now, I'll admit, there is still some lively debate in the literature and in cadaveric dye studies regarding the exact mechanism. Does the injectate physically enter the thoracic paravertebral space, or does it simply spread along the fascial planes to bathe the celiac ganglion of the sympathetic trunk via the splanchnic nerves? The exact pathway might be debated, but the clinical reality is not. Targeting the lift ensures a highly consistent, profoundly deep, visceral and somatic analgesia.
So, let's address the elephant in the room. Why go through the trouble of a QL block when we can all do a TAP block in our sleep? Let's look at the hard clinical differences. The standard TAP block is a fantastic tool, don't get me wrong, but it is strictly limited to somatic coverage, generally capturing the anterior abdominal wall from T6 down to T12. Furthermore, because you are injecting into highly vascularized, active muscle planes between the internal oblique and the transversus abdominis, your local anesthetic is cleared relatively quickly. The pharmacokinetics work against you. The QL block, however, is a different beast entirely. It provides both somatic and visceral coverage, typically from T7 solidly down to L1. Even more crucially for our enhanced recovery pathways, the duration of analgesia is significantly longer. Why? Because our injectate is spreading into the relatively avascular, fat-filled paravertebral spaces and deep fascial planes. This results in a dramatically slower rate of vascular absorption. Plus, as we discussed, you are achieving that invaluable sympathetic nerve blockade that a TAP block simply cannot touch.
Section 2. The 4 QL approaches.
With the foundational anatomy set, let's break down the 4 distinct ultrasound-guided approaches to navigating the QL muscle. The nomenclature we use here is quite logical. It's based entirely on where your needle tip ends up in relation to the QL muscle itself. This matrix is one you'll want to commit to memory. Starting with QL1, the lateral approach. The patient is usually supine, your needle direction moves anterior to posterior, usually starting around the mid-axillary line. You are targeting the anterior lateral border of the QL, right where it forms a junction with the transversalis fascia. Tactilely, this feels very similar to a posterior tap block, but you are deliberately pushing slightly further posterior. Next is QL2, the posterior approach. Here, patient positioning matters. You ideally want them in the lateral decubitus position, though supine with a good wedge under the flank can work in a pinch. Crucially, your needle trajectory completely reverses compared to QL1. You are driving posterior to anterior. You are targeting the posterior surface of the QL, aiming precisely for that lift area we just discussed, separating the QL from the erector spinae. This gives a highly predictable spread toward the paravertebral space. Then we have QL3, the transmuscular or anterior approach. Patient must be in lateral decubitus. Needle is posterior to anterior. You are aiming for the anterior surface of the QL, meaning you actually pass through the muscle to inject between the QL and the psoas major. This approach arguably provides the most extensive cranial spread, potentially blocking somatic and lumbar nerve roots, but make no mistake, it is technically the most demanding and carries higher risks. Finally, QL4, the intramuscular approach. Patient supine or lateral, needle anterior to posterior. You simply drop your local anesthetic directly into the belly of the QL muscle. It's technically the easiest to perform, acting as a simple depot, but it offers the most limited, localized effect.
Let's map those trajectories visually. When you look at the mechanics of the needle pads, the top left QL1 trajectory shows the needle coming from the anterior aspect, passing through the abdominal musculature, and coming to rest just on the lateral edge of the QL. In stark contrast, the top right QL2 trajectory requires the needle to come from the posterior aspect, aiming for that distinct fascial plane behind the QL muscle, wedging it apart from the paraspinal muscles. And then, look at the bottom image for QL3. Here, the needle takes a much steeper, far deeper trajectory. You are passing straight through the erector spinae, plunging right through the QL muscle itself to deposit the drug in that deep, hidden tissue plane between the QL and the psoas major. As experienced clinicians, you know that mastering your probe manipulation is the secret here. You almost always need to drop your high-frequency linear probe and switch to a low-frequency convex probe to visualize these deep, posterior structures with any sort of clarity. If you are planning to attempt the advanced QL3 transmuscular approach, your absolute non-negotiable prerequisite is identifying the shamrock sign. Beautifully described by Dr. Jens Berglund back in 2013, this sonographic landmark is literally your map to safety. You start by placing your curvilinear probe at the flank, transverse to the spine, and slowly slide posteriorly until you see this distinct, 4-part shamrock shape emerge on your screen. The solid stem of the shamrock is the dark acoustic shadow cast by the L4 transverse process. Sitting right there is your anchor. The posterior leaf of the clover is the erector spinae muscle. The anterior leaf is the psoas major. And the lateral leaf is the Quadratus Lumborum. Your needle target is the incredibly specific fascial plane nestled exactly between the lateral leaf, the QL, and the anterior leaf, the psoas. Visualizing this perfectly and tracking your needle tip every millimeter of the way is exactly how we avoid catastrophic intraperitoneal injection or inadvertent renal injury.
Section 3. Dosing and Procedure Guidelines.
Now that we know exactly where to put the needle, we need to talk pharmacology. The success of a QL block relies heavily on volume. This is a true fascial plane block, which means we need shear volume to achieve adequate hydrodissection and cranial spread. 20 to 30 milliliters per side is the standard requirement. In weight-based terms, we are generally aiming for 0.2 to 0.4 milliliters per kilogram. If we try to skimp and use low volumes, say 10 to 15 mils, the local anesthetic simply will not have the hydrostatic pressure to pry apart the fascial planes of the TLF. It won't reach the thoracic paravertebral space, and your block will fail to cover those crucial upper dermatomes.
Let's review the drug specifics because with volumes this high, the math matters. We have choices here, primarily our trusty long-acting amides. For ropivacaine, we typically utilize concentrations between 0.2% and 0.5%. For bupivacaine or levobupivacaine, we're looking at 0.1% to 0.25%. Now think about the math for a moment. Because we are injecting 20 to 30 milliliters per side, that means a bilateral block requires 40 to 60 milliliters of local anesthesia. Carefully calculating your maximum systemic dose is absolutely paramount. You do not want to get caught out by bilateral dosing. For bupivacaine, as we know, we cannot safely exceed 2.5 milligrams per kilogram, so a standard adult protocol might utilize 30 milliliters of 0.25% bupivacaine per side, which gives you exactly 150 milligrams total, well within safe limits for an average adult, but you must run the numbers for every patient. As for adjuncts, adding 2 to 4 milligrams of preservative-free dexamethasone per side is highly recommended. Current robust meta-analysis show that perineural dexamethasone significantly prolongs the duration of the peripheral block and noticeably potentiates the overall quality of analgesia.
Section 4. Clinical Indications and Evidence.
So does the clinical evidence actually support all this complex anatomical theory? Emphatically, yes. Let's look at cesarean deliveries first. Dr. Blanco's pivotal 2015 randomized controlled trial directly compared QL blocks to standard TAP blocks for C-sections. The results weren't just slightly better, they were definitively clear. The QL block was vastly superior, demonstrating significantly lower morphine consumption all the way up to 48 hours postoperatively. A massive subsequent meta-analysis by Singh confirmed this trend, showing an average reduction of nearly 10 milligrams of morphine in the first 24 hours compared to controls. It's worth noting, network meta-analyses suggest that if you are already using intrathecal morphine, adding a QL block might not offer massive synergistic benefits, but in the absence of ITM, the QL block reigns supreme. Now consider nephrectomies. Multiple major RCTs have evaluated the QL block for open and laparoscopic nephrectomies, and the results are staggering. The QL block provides an opioid reduction that is practically equal to a continuous thoracic epidural. But here is the massive advantage. The QL block avoids the profound hemodynamic crashes and hypotension. It drastically reduces severe postoperative nausea and vomiting, and it doesn't tether the patient to a urinary catheter, allowing for much faster bowel recovery and earlier discharge. It provides the profound pain relief of a neuraxial technique without the systemic drag.
Beyond C-sections and nephrectomies, the QL block is rapidly establishing itself as an absolute cornerstone of enhanced recovery after surgery, or ERAS protocols worldwide. We are utilizing it with immense success for laparoscopic cholecystectomies, major open bowel resections and colorectal surgeries, open appendectomies, and highly complex gynecological procedures like radical open hysterectomies. But its utility doesn't stop with adults. It's gaining serious traction in pediatric anesthesia for procedures like umbilical hernia repairs, where we use tightly calculated dosing parameters, usually around 0.1 to 0.2 milliliters per kilogram. Fascinatingly, we are even seeing expanding utility in chronic pain management, particularly for patients suffering from persistent pain following complicated abdominal hernia repairs. The theory is that the block effectively resets the autonomic tone of those irritated fascial nociceptors.
Section 5. Safety and Complications.
Now, while the QL block is generally considered much safer than deep neuraxial blocks, primarily because our needle tip stays relatively far from the neuraxis and the peritoneum, we must remain highly vigilant regarding complications. First, we need to talk about lower extremity weakness. Retrospective studies indicate an approximate 15% risk of inadvertent quadriceps weakness. Why does this happen? Because our high-volume injectate can spread directly caudally into the roots and branches of the lumbar plexus, specifically L1 through L3. This complication is by far most common with the deep QL3 transmuscular approach. Because of this, explicitly warning our patients, the surgical team, and the ward nursing staff about potential falls during early mobilization is critical. Second, local anesthetic systemic toxicity, or LAST. Because we are injecting massive volumes into relatively avascular fascial planes, the absorption kinetics are unique. Marucci's pharmacokinetic studies are vital here. They showed that while arterial ropivacaine levels generally stayed safely below the toxic threshold, the peak plasma concentration didn't actually occur until 30 to 60 minutes after injection. This means LAST might not happen in your block room. It could present an hour later while the patient is in recovery or on the ward. We must be incredibly careful here, especially in pregnant patients who inherently have increased cardiac output, faster injection site perfusion, and decreased alpha-1 acid glycoprotein levels, all of which increase the free fraction of the drug. Additionally, you need to watch out for bilateral sympathetic blockade causing unexpected delayed hypotension, and always be aware of potential hematoma formation due to the highly vascular nature of the paravertebral space.
To ensure absolute patient safety, we must adhere strictly to our contraindications. The absolute contraindications are clear-cut and non-negotiable. A known, documented allergy to enamide local anesthetics, active infection at the injection site in the flank, overwhelming systemic sepsis, and severe coagulation abnormalities or bleeding tendencies. Let me be clear. If your patient is fully anticoagulated, a deep QL3 block is entirely off the table due to the incompressible nature of the deep muscular layers. Relative contraindications require our clinical judgment. These include pre-existing neurological deficits, especially existing lumbar plexopathies or neuropathies. In these cases, we really don't want to muddy the diagnostic waters with a block that might cause temporary motor weakness, making post-operative neurological assessment impossible. Also, you must proceed with extreme caution in patients presenting with severe hemodynamic instability, as the potential sympathetic block from a bilateral QL could precipitate cardiovascular collapse.
Colleagues, to wrap up our review today, the Quadratus Lumborum block represents a massive, undeniable leap forward in truncal analgesia. It beautifully bridges the gap between the superficial simplicity of a TAP block and the profound, undeniable visceral coverage of a thoracic epidural. It minimizes the need for systemic opioids, it bypasses the nasty side effects of neuraxial techniques, and it actively accelerates patient recovery. Yes, the regional anatomy is complex. Yes, the needle trajectories require precise sonographic mastery. And absolutely, the massive volumes demand our utmost pharmacological respect and vigilance. But when executed correctly, the clinical outcomes for our patients are simply phenomenal. So I leave you with this final provocative thought to consider for your own daily practice. Given the extraordinarily powerful somatic and visceral analgesia it so reliably provides, what is the QL block's ultimate role in your institution's ERAS protocols? Are you ready to elevate your truncal blocks? Thank you so much for your time today, and exceptional luck in the theater.